Before we get started, just so I can kind of maybe try and talk more about what people want to hear, I wasn't quite sure who we were going to have here audience-wise and how it was going to break down in terms of what people are most interested in. So who's mostly on the analyst side of things? Raise your hands. So like half-ish. And like who is a investigator? So like kind of the other half-ish. All right. So I guess what we're going to try and do then is talk a little bit about what these data are that are available, with a focus on what IHPI has ready access to now, realizing that is not necessarily all HCUP data. And then simultaneously have the other thread be focused on examples of things that you can do with this type of data that has worked well and ended up in relatively high impact publications. Before we do that, though, I'll tell you who I am. So I'm Jim Burke. I'm a stroke neurologist and health services researcher here. I've worked with the state inpatient databases a fair bit, and we'll talk at the end about a tool we've been working to develop to try and make it easier to work with them. And so I know that in a reasonable amount of detail. I've also worked with the nationwide patient sample a little bit, but not quite to the same extent. So I'm going to give you guys kind of like a quick overview and then go from there. All right, so first off, everyone's probably heard HCUP, HCUP. It means the Healthcare Cost and Utilization Project. Everyone's heard of that, more or less? Okay. So it's administered and funded by the Agencies for Health Research and Quality, HRQ. And this is one of the big budget items for HRQ. They spend a lot of money on HCUP, which does a bunch of things, but a huge thread of what they do is about collecting and organizing administrative data. And their process is pretty straightforward, which is basically every state has a clearinghouse. And that means that every single hospital in the state will send all of their administrative data to this clearinghouse. And it's a different organization in every state, and every state does it a little bit differently. But so in Michigan, everyone who comes from U of M or St. Joe's or whoever, all of your administrative data goes to the state. What the state demands that you send them data-wise varies state by state. After the states collate that data, what they'll have is a set of data that says in Michigan in 2011, here's a record for every hospitalization and or ED visit and or ambulatory surgery visit. And then all that data goes to HCUP, who kind of cleans it up, plays around with it, and then redistributes it. And that's really the bulk of what they do, is they take all of that different data and they put it together in different packages, and you can pick up a different package based on what type of analysis you want to do. So currently they've got nearly perfect penetration. They've got 48 states from all hospitals, and thus payer independent. And they've said as of 2013, they had 95% of all discharges in the United States. So as of right now, they've got nearly everything if you're in a hospital in the United States. That's not at all true going back. So this falls off really quickly as you go back. So if you make it back to the mid-2000s, this is like 25 states. And if you go back to the early 2000s, late 90s, you get down to like 10 states. So it really kind of shot up astronomically. But as of currently, they've got near perfect penetration. And I put a couple links in here if anyone, well, I think you'll have access to the slides later on. Everything is really actually pretty simply documented on their website. So I'm not going to go through a lot of the nitty gritty and excruciating detail because you can just go look it up better than I can explain it to you. So like I said, they take that data, slice it up, and put it in a bunch of different products. These are the big ones. So who's heard of NIS, the Nationwide Inpatient Sample, right? So what this is now it's a sample of all hospitalizations or all discharges in the United States within a given year. And basically they pull from that giant data source to give you a survey-weighted data set representative of all hospitalizations. KID is basically that from pediatric hospitals, and so you can use it there. NEDS is the National Emergency Department sample survey, I can't remember which pulls from the ED-based documentation. So here they have, when I talk about the 48 states and near complete penetration, that was for inpatient hospitalizations. They also collect data on ambulatory surgery as well as emergency department patients that are not hospitalized. And I think they're up to 20-ish states, somewhere in that ballpark now. And they'll take that data and, again, pull together a weighted sample of all ED visits in the United States. They call that NEDS. Their new product that I know nothing about is the National Readmission Database. And so they're, again, taking data from SID and then turning that into a nationwide estimate of what happens to readmissions. And then sort of the core things that they use to build all of those weighted samples out of are SID, SASD, and SED. So SID is the state inpatient databases, and that is kind of the Michigan gives HCUP the data, HCUP cleans it up a little bit and sells it to you as a product. SED, same concept, but now for emergency departments. And then SAS-D, this ambulatory surgery database, the state ambulatory surgery database, does the same thing, but now for ambulatory surgery visits. So you can get of all sort of acute care, high intensity care, it's all captured, but there's no outpatient anything anywhere as part of any of this, which is a major gap compared to other things.
Are we allowed to ask questions?
Please. As you started to raise your hand, I was going to interrupt you to say, please ask questions.
So the kid, just has a larger pediatric sample than the NIS has?
I believe so.
Okay.
So I think I've not worked with it directly. Yeah. I've got a reference to what it is. I believe what they've done, and anyone jump in and give me if I'm wrong. I've not worked with this. I believe this is basically they sample from the universe of pediatric hospitals, and you have a hugely weighted, basically NIS is something like 6 million hospitalizations per year, and you weight it up times 5, and you get 30 million in the U.S. Yeah. KID is same type of concept. So if you just took out of NIS all of the visits in kids under 18, which are in there, yeah, you'd have a tiny little sample. KID sort of beefs that up, so you've got enough sample size to be able to do stuff.
Got it.
Does NIS and NIS are somehow connected? Like if a person goes to emergency and needs.
Not now. So they're not. You can do that with the state level ones, right? And so we'll get to that, or we'll talk about that at the end. Basically, NIS does not have a identifier that is linkable to anything else. So if those 4 basically are existing in isolation, not really linkable to anything else. You're going to start and end there. The state-based ones, and we'll talk about this in a little more length, do have the possibility of being linked to other data sets and each other. That's right. Yep, exactly right. All right. So the nation is now called the Nationwide Inpatient Sample. It was fortunately the Nationwide Inpatient Sample, and they actually changed the design of NIS back in 2012. So what they did prior to 2012 was they took a bunch of hospitals. So there's let's say 3,500 hospitals that they would have data on. They took a quarter of those hospitals and then put in every single hospitalization for those hospitals and then applied some survey weights to try and come up with a national estimate. So it was never really truly an estimate of hospitalizations. It was a sample of hospitals. This was convenient if you wanted a really big convenient sample of what happens in hospitals because you had everything within a hospital within a year. They changed it now so that it is more a representative sample of all hospitalizations within the United States within a year. But what that means is you can't really use it for getting a hospital. So before it used to be if, let's say, U of M got included in the sample in a year, you would have every single U of M discharge for the year. So you'd be able to look and say, what was the count of cabbage claims at U of M in a given year? You can't do that anymore because U of M, to the extent it's in there, you will have just sort of a sample of hospitalizations from U of M. And so it's basically, it's about a 20% sample of all hospitalizations nationwide, and they do complex survey weight design that we could talk about at great length, but I'm not going to talk about it all because their documentation is fantastic.
So if you want to do a trend analysis, is it possible to merge NIS over time?
Yep. They have technical papers out your eyeballs about how to do that. And so they have, if you go to the NIST documentation site, they will give you data, or they will give you exactly what you need to do trends analyses over time that they believe are going to be representative comparably. I haven't seen one that crosses that boundary yet, and I will bet that if you see a trend that's stepping upwards, that you're going to see a discontinuity when they redo the sample, but I doubt it's too terrible with that. So I haven't seen one that bridged it yet. I couldn't find one. I looked for one the other night, couldn't find anything. SID, and I'm going to talk about these two in a little more length because these are the ones that we have IHPI-wide considerable access to. So as I mentioned, it's all community hospital discharges within a given state year. Community hospital basically just means if it's a federal, this does not include the VA, right? And so it doesn't include the VA and military hospitals and some state-run facilities, but it basically means it's what we think about as hospital care. It's darn near all of it with the exception of some isolated systems. 48 states. And one of the annoying parts about working with SID that we'll talk about at the end is that, this happens with NIS and it happens particularly with SID, is that you'll kind of get a little bit of a different data set every year. So if you're just working with Michigan 2011, it's one data set, everything's nice. If you want to work from Michigan 2004 to 2011, you'll find that one field changed, another field came in, 2 fields came out. And then when you do that for a bunch of different states and years, now this problem gets to be not necessarily nightmarish, but at least substantially inconvenient. All right, so quickly going to talk a little bit more NIS, what's in it, what's it good for, what's it good or not good for, and good for, and then how do I get it and use it? So said this first thing about 10 times already. The data set is broken up into a couple different files, but conceptually all it is a row is a discharge, right? And so a row is not a patient. This is not a sample of patients. You could have one person who's admitted 100 times who ends up in this data set 5 times, and you're not going to know who that person is, right? You're just going to know that it's a data set of hospitalizations. It is in the ballpark, and it varies a bit per year in terms of the number of discharges that go into the sample. It's millions per year, usually someplace in the 5 to 10 million discharges per year. The data elements are basically the things you expect to see. Actually, pause. Who's worked with any type of administrative claims data at all? Most everybody, right? So the format's going to be fairly familiar. It's fairly clean and simple to work with. So you're going to have 25 diagnosis codes, ICD-10 or ICD-9 historically, switching to ICD-10 shortly. I think their most recent year is still in ICD-9. Same for procedure codes, here only in the ICD-9 procedure coding framework, not via CPT codes. You got patient demographics and who are the payers. You've got some hospital characteristics, but not actual hospital identifiers anymore. So historically, you had hospital identifiers that were plausibly linkable out. In the more recent versions, all you have are hospital identifiers. You can say, was it a teaching or non-teaching hospital? You can figure out what region it was in. I think they have a bed size factor, and they have an ownership factor. So they've got a couple of things that sort of describe the hospital, but you're not going to be able to actually identify the hospital. And then they don't have much in the way of granular charge data. They have a overall total charges element for that hospitalization, which sort of slams together all of the hospital charges. You've obviously got some characteristics of what happened while you were in the hospital. So where'd you go? How long were you there? And then you've got they've got their severity measures and comorbidity measures, which are all built off of this. So they've got these third-party severity adjusters, APR, DRGs, and a couple other types of DRGs, where basically somebody else has built a model to predict mortality within a given diagnosis, and they say we ran that, and you can, if you want to look at like lots of different diagnoses simultaneously, this is a convenient way to do it. You can sort of say who is mild, moderate, or high, low, medium severity based on risk of immortality, for example, using those monitors. And they have the Elixhauser comorbidity measures sort of auto-generated that you can just use automatically without having to do anything.
The cost to charge ratio, like SID is available for some states. I think it's also available for
it is. Yep. So I mean,
all throughout all years.
I believe, yeah. So I believe they have it for NIST as well. So yes. So you can take these charges and turn them into a cost-like concept, where they basically say at this given hospital. I mean, it's really, really crude what they do. I mean, this is not like anything terribly elaborate goes into it. But basically, they took a multiplier at the hospital level, and they said, this hospital, whatever you charge, actual costs are, we're going to reduce that by 60% or something like that. And it comes up with different numbers for every hospital. The methodology for how they do that is, basically they're trying to align it so that your charges look like your payments. As they sort of take, I believe, how they did it. And so they're just trying to come up with an approximation of costs. But it at least gets you onto a scale that looks like an actual number as opposed to something that's thoroughly, totally made up, like charges. So that's basically what's in there. We'll talk a little bit more about what you do with it momentarily. All right, so what's it good for, right? And so 20% of all hospitalizations in the United States, but you don't know who a person is. You don't know what a hospital is, right? You can't necessarily do everything with this data, even though you have a gigantic data set. So they say that they always like to talk about it as being used for rare diagnoses. That's true, because we get 6 million hospitalizations. You're going to have every rare diagnosis in the world show up there. The problem is that never actually works that well, because those ICD-9 codes are all unvalidated, and who only knows what happens when you click a rare diagnosis code. So I don't think that's quite so convincing. I mean, the things where I've seen this be used well are for trends data, where I think it's really great, because you can go back over time and say what's happening in the United States. You can do what happened with big picture policy changes, and there's been a bunch of analyses that did this well. So one state changed something and its neighboring state didn't, and let's see what happened to something we can measure in terms of utilization. It's not a bad geographic variation data set. You will get the state where somebody's at, and so you can sort of see coarsely how much things are changing in one region or another region, and you get a big picture sense of this overall charges and costs, right? What is expensive? What is inexpensive? How are those things changing over time? You can get a sense of all of those things. I think that's when it's been used best. And then let me give you a couple examples of what it's been used for. So this is something I stole from Will Moyer. And so the y-axis here is the proportion of all ischemic stroke that receives IV TPA, which we know is a little bit undercoded, going from 2000 to 2007. And first off is we're miserable, right? I mean, we're treating a tragically small proportion of people with this highly efficacious medication. We're doing better over time, and policy really actually matters. January 2005, they bumped the DRG for TPA, and you have a abrupt slope change subsequently. And actually, when we have this pulled forward, it's actually, this was the outlier. It looks like that ever since, and it's been going up ever since that time. So this type of big picture policy change, when we did this incentivize anything? How much did it do? We can project what it would have been in the two different policy scenarios and do it. And then moreover to say, well, we've still got a long ways to go, probably. We probably should be able to get this to at least 10% nationwide if we really tried. So we've got a ways to go, but at least we're moving in the right direction.
Can you identify a state so if the policies at the state level can be compared to states?
Yeah, so I am not 100% confident on the new sample. On the old sample, for sure you could. And I believe they still have a state identifier in there. Now you get into all kinds of inference problems about what to do with the weighting, because it's not a sample of hospitals within states within. So, how you generalize isn't clear, but using it as a gigantic, convenient sample, I think you can argue you could probably do something reasonable at that level, but I wouldn't know what to do with the weights.
Do you have zip codes of where patients are in hospitals to look at?
They don't here. They do in SID. And so what you have here is, I think the only geographic identifier here is they've got they take your zip code, map it to census data, and tell you which income quintile your income is, or your zip code is. So, you don't have the actual zip codes. You can't link it to anything else. So I mean, really, I think this is very true of NIST. This is something where linking in anything else is intentionally hard to do.
And instead, you have to be careful because some states don't have it, like California doesn't have the zip code of patients. So it varies state by state.
So SID is borderline devious with this, because sometimes they'll put a zip code field in there, but it's the hospital zip code as opposed to the patient zip code, and sometimes it's the patient zip code, and some give you 3-digit zip codes, and some give you 5-digit zip codes. And this becomes the problem with working with SID. But many states will let you know where the patient lives. All right, another good example of this. This is actually from KID, but you get the same idea of what happens here. And the neonatal abstinence syndrome. So essentially, babies born to mothers using opioids during pregnancy. We knew that we had an opioid epidemic in adults, and this results in a tripling in the likelihood that you have this diagnosis coded while you're in the hospital. And then when you look at charges in these kids, which are already astronomical outliers, that you had a higher proportion increase in those people over time. So I think that this is, again, sort of an example of how this type of data really gets people's eyeballs. And you say, look, we're now talking about, yes, we think opioids are a problem in general, but this is another way of demonstrating how that problem doesn't just stop at one place, it goes on, and how it has economic consequences. And I think that this big picture type of where's the stuff going analyses are really good. And there's all kinds of other clever things that have been done. I thought this was super clever. So basically, there's this purported idea that we're going to rank hospitals based off of what is their mortality for different conditions. And you said, well, the problem with that is that most hospitals only do a small number of any one type of procedure, and that means we've got poor reliability about trying to classify that hospital. And you say, how many of them can we actually classify based on their real-world volumes? And we can maybe do bypasses, right? And everything else, the volumes, if you're going to be able to reliably detect any real-world difference there based on what their reported mortality rates are, we've got big, big problems. So this is sort of using the old NIST design where you had everything at a hospital level, but it was, I thought really clever to go out there and say, look, what is the real world distribution of the number of cases of each of these things relative to their mortality rates, and basically using that to power sample size calculations and saying, how much of a difference could I detect at what's already out there? And that was another way to use this to sort of inform policy. Okay, so the how do I get it part. So Patrick's not here because the right answer to this is talk to Patrick. Does anyone know Patrick Brady? Most heads nodding up and down. Some smirks. All right, good. I'll pass that on. So Patrick is the gatekeeper for all of this right now. IHPI has, I think, 2008 to 13 available. There's a bunch of people who have it for more years than that. Phyllis, perfect.
I was going to say, for IHPI consolidated where we have 2003 to 2015. So we actually have for most of the states 2003.
What about NIS? So for NIS,
For NIS, actually,
2008.
I have on CHOP, which is
Yep.
it's 1998.
Good. Okay.
1988 to 2013.
I thought we had it going back way further. So
Right.
Patrick sent me this, so give him a hard time. No, okay. So
It changes.
we've got it going back for forever in terms of being able to do trends. Cost and availability things are all things that are right now Patrick questions. But I think the short of it is that costs are not likely to be a giant barrier for anybody going forward. This is all pretty reasonably available through IHPI. The data use agreements are pretty liberal. And this is not really NIST relevant, but we've got, as Phyllis is pointing out, from 2003 to 2013, essentially consecutive data from all of those states, and then some other outlying state years that we've got kind of pieces of the puzzle, but not quite the whole thing yet. And this is a gigantic sample. So if you look at that, that's something like 200 million hospitalizations. I mean, it's a ludicrously large number that we have it from. It's, there's this arbitrariness where these states are selected really from a convenience fashion. And having had to write that in methods section several times about why these states, I always kind of blush as I try and justify them. I was like, well, those are the ones that were big and cheap, and that's pretty much why we did it. Big, cheap, and available. But it is regardless really big. And when I've compared this for stroke, for example. When you look at the NIST stroke population as opposed to a stroke population pulled from this, they look identical in terms of everything that's measured. So we look at comorbidities, we look at demographics, we look at insurance profiles, all the things that we can measure, they look the same. I think there's probably a pretty good representative's argument there. Okay, using it, here's another good, this is you go to this link's actually very good in terms of having all of the detailed stuff that you might ever want to know about NIST. It's actually a pretty relatively usable website, so you can always go there. The data files are distributed as 4 files. Really all you need is the core file. That's where kind of the main things are. They sort of break out other chunks as well. If you want the weights, you can bring in the hospital weights. They've got a separate file where they'll come up with different ways of coding the diagnoses and procedures that you might want to use. So they've got their clinical classification system that's HCUP, so that you can pull them out that way. And then the severity features come in another file, but you can oftentimes just work with core. If you want to generate your comorbidities off of that, you can. They're all decent-sized files, and they have, for recent years, they've got SAS data and SPSS load files available via their website. You just download them and put them in. And the survey weighting is all very, very straightforward. You can find template code on their website about how, for whatever your package is, to do the survey weighting. And if you want to do something complicated like trends, there's technical documents about how to do that going back over time. All right, so this is too small. I've already alluded to a lot of this. So really the magic of SID is that it's fantastic for hospital level analysis. And this is really what it shines at, because you've got, particularly when you go across a bunch of states, you now have a huge sample of hospitals. And this is usually our problem with hospitals, is that we only have 50 or 100 hospitals, even in a large sample. This is something where you can have a very, very large sample of hospitals. And unlike, say, working with Medicare data or Optum data, you've got everything at that hospital level, right? And so you have you have all payers, you have all the discharges, and you have all ages. And so depending on what diagnosis or what condition you're worried about, that's a big deal. Also, too, if you're interested in looking at what hospitals do across conditions, this is great. And the sample size is ludicrous. We'll talk about this in a little bit, but SID, many states give you more granular detail on utilization. And so you can get a little bit more about what happened and where the costs went. You have the capacity now for doing revisits, looking at readmissions in particular across some SID states. Similarly, using the same mechanism, linking between SID as well as the emergency department database and SASD. And then you have hospital identifiers that you can also link out. They've got AHA IDs. So if you want to bring in hospital level information from Medicare or from AHA, you can do that as well. And then some of the states throw in delightful little idiosyncratic elements that they just happen to do. I'll give you an example of how one of those turned really useful. The main disadvantage, and I think I've already mentioned all this, is that this can be working with big data sets. It gets a little bit unwieldy because now you've got one field's coming in from one state year, and one state tells you this, and one state doesn't tell you this. So trying to get your analyses aligned over state years can be something between impossible and annoying. It's really expensive, and this is a point where the broad IHPI investment makes this much, much more accessible. So we're talking about state years. They vary hugely from state to state. Like California was ludicrously cheap, so everybody had California. But a lot of these, for a single state year, we're talking like $1,000 payment. And so to be able to get lots of states and lots of years took a lot of money. And then there's the question of representativeness. I'm pretty satisfied it's probably pretty representative of the overall U.S. population, but I suspect that's, depending on your condition and depending on what you're studying, that may be a problem. And, like I said, writing those 3 sentences in the methods is always a little inconvenient. All right, so here's the granular utilization part comes from what many of the SID states do is HCUP has generated these utilization flags for a whole series of different things that can happen in the hospital. So did you get physical therapy? Did you get occupational therapy? How much did you get, or what were your overall pharmacy charges? Essentially what they do is they take all of your charges and they sort of bundle them and generate flags off of them. That's generated off of mostly UB92 revenue codes, and then also whether or not you have an ICD-9 procedure code generated. For most of these flags, it's generated off of the revenue codes. I mean, they've done, HCUP has done some validation work on the flags, and they look like they're probably, for the most part, pretty reasonable. Like, in all the cases where I've played with them, the face validity has been really good. Like, they've definitely made sense. I've come to trust them the more that I've used them, although they don't have fantastic real-world utilization stuff. But this is work we did with the use of MRI and CT in stroke. And sort of what you had here was, I think this is in the year 2008, you saw there was huge geographic variation in the probability of getting an MRI. So if you were in Oregon, it was 55%. If you were in Arizona, it was almost 80%, which is probably close to everybody who doesn't have a contraindication, right? So like 1.5-fold statewide aggregate geographic variation. And then you can sort of see like the temporal trends, right? Everybody always got a CT. We were kind of pinned out there. But across all states, highly symmetric stepping upward trend in the utilization through the use of those flags. And then you can also do this you can do this granularity also at the cost level, right? If you want to sort of break down where is our money going for this hospitalization into big categories, you can look at things like room and board, ICU, pharmacy, diagnostic imaging, diagnostic labs. And for stroke, we sort of had a big move upward. Diagnostic imaging used to be down here, and actually, if you take this forward, it's now the biggest component. It's past room and board.
How do you break down the cost? Because there's just one charge per admission.
So not in SID. So SID. So this depends on the state year that you have. But so many of the state years will have they will code it different ways, and it's cleaned up. There used to be like at least 3 or 4 different ways this was done. Now it's down to basically 2. Most of them will give you a wide file, or a long file, where they'll say for the key for this hospitalization, they'll say you had revenue code X, which represents an MRI scan. You had 2 units, and the cost was $1,200. And so you can basically take across those revenue codes and break them out into chunks. And so this was sort of like when you look at the revenue coding schema system, if you just look at the list, 0100 to 0199 are all room and board charges. So you can sort of sum all of those costs. These are all pharmacy costs. These are all, lab costs. And we sort of, broke those into big chunks and put them up this way.
So there are ways to break them down.
Yeah. So you have to have a state year that has revenue codes. If you're looking at the HCUP database, it's the availability of the U flags in recent years. Or historically, it was do they have a charge 1, charge 2, or a rev code X? Right? If you had those things, you're able to get this more granular data. So again, depending on what you're interested in, this is either a really big deal or something you don't care about all that much. But it lets you go beyond just someone who was in the hospital and cost $10,000 to what happened that made it cost $10,000. You can kind of dig down into it. Another thing. And again, that's for discharge per discharge. Correct. Yes, exactly right. Per discharge episode. The other thing that you can do, and you don't look at this. The point of this is to show you that there are lots of things, as opposed to show you any of the specifics. So what you can do is, with many of the state years, and you've got to go to their website to see which state years you can do this, you can now track patients across the SID or across SID, SED, and SASD. And so what they do is basically HCUP takes identified data, de-identifies it, but gives you a linkage back so that you can put these files together. So for the linkable years, every patient gets a unique identifier called a visit link. And so basically just a number that represents now not a visit, but a patient. And you also get a arbitrary number, which they sort of rescale for every patient, which is like on the day's time scale for that patient. So it might be the number 10,000 and you're admitted 100 days later, right? You'll have one row for that patient that says patient number 10,000, and you'll have one 100 days later that says patient number 10,100. right? And you can figure out the delta between those dates, but you can't figure out the actual dates. So you can't actually know this person was admitted on January 1st, of this year, and also readmitted on this day. But if I say this person was admitted now, they were readmitted 100 days later. What that lets you do is look at, if you're interested in, again, let's say you're interested in ambulatory surgery and the odds of being hospitalized in the 90 days after that, you can take the SASD records for your surgery and then go pull out the hospitalization records and see who ended up getting admitted. If you're interested in readmissions, you can take an index admission and then look at what happens subsequently. That's what we did here for stroke. So CMS is now reporting, as I'm sure many of you know, at the hospital level, mortality and readmission measures for a whole bunch of different things, including stroke. Only nobody had any idea how to do anything about that for stroke. And so we took essentially everything we could measure at the hospital level and said, do hospitals that do more of anything influence the probability that you're going to be readmitted? And depending on your perspective, the depressing or interesting answer was basically no. Like looking at more or less the 100 different things that hospitals could do, we couldn't find much in the way that influenced this other than maybe a little more occupational therapy. Everything else we found was pretty modest in terms of this. I don't think this is the most interesting. I think the readmissions and the linkability part of this is a part where this has been hugely underutilized. There's been a lot of readmissions work in Medicare, but I think that, like, again, for stroke, stroke in the elderly is probably a substantially different disease than stroke in the young. And so, what happens for readmission in those two different populations is both an interesting clinical and policy question. And, this allows you to start digging at that and getting at a whole lot of cool stuff that you could do there. And then I'll give you one example of what I mean by this sort of idiosyncratic data element stuff. Whatever you're thinking about using this, like going through and spending some time browsing the data documentation, you might find something cool. So California has a field where they wrote whether or not for admissions, whether or not you had a DNR order written within the first 48 hours. Like, what exactly that means is not entirely clear, and the interpretations are not super linear. But what you find is when you look at hospitals for stroke patients, there's huge variation in the probability that you have a DNR order. I mean, essentially like nothing. The lowest quintile, nobody has a 48-hour DNR order. And the highest quintile, it's like 32%. So there's gigantic variation in the likelihood of having this. And that this kind of gets that adjusted mortality and readmission concept again. When you kind of look at mortality here, you see that it tracks up, the mortality is the lighter gray bar. It goes up a lot with those DNR orders. And so when people die from stroke, they die mostly because we let them die. We stop doing something at some point in time. And if that's what's happening with all stroke mortality, this probably isn't the sort of thing we should be reporting, as I keep saying and no one listens to me. But so, this I thought was just crushing. So we came up with an adjusted mortality measure that said it was sort of similar to the CMS measure, although it's inpatient mortality. And then we did that just adding whether or not an individual had a DNR. And like the mortality measure, you're getting one hospital ranking on this axis and the other hospital ranking on the other axis. And like all of a sudden, just putting that one factor in, you would completely, utterly alter your perception of hospital quality. So like, this poor hospital over here is either like one of the like 70 worst hospitals in California or the 70 best, right? Like, just by saying, is this DNR thing something that we should care about? And so, if you're interested in working with SID data, spending like a half an hour poking through on the website going, ooh, what's that? You might find something that's kind of cool that one state reports. And there's a whole bunch of these little random things. I definitely don't know them all idiosyncratically, but I thought this really kind of helped us